played the game the other day. It was more advanced than what us old schoolers liked. So, unfortunately, I don't have another game to play. So we're going to do the lecture, the ones that's been through ASU Mountain Home's paramedic program. This will be probably the most boring hour of their life. Second most boring hour. The first hour was probably when they went through it the first time. Now they get to go through it again. The operations? Is that what you said? All right, so I'm not going to I'm going to go more in depth. I'm going to skip over the stuff that we do know that we are more aware of. Once I do in class, usually we just look at the pictures, the cool pictures. This is 179 slides. We're not doing that. All right, so we all know our trachea represents the trunk and the alveoli represents the leaves in the inverted tree. The tracheobronchial tree, also known as the windpipe, is the trunk of the tracheobronchial tree, carries air to the lungs, extends about 4 to 5 inches from the larynx to the left and right mainstem bronchi. The ridge-like point where the tracheal cartilage bifurcates is the carina. We all know this. At the level of the 5th intercostal space. Oops. Back. The right mainstem bronchus typically branches at a less acute angle than the left. As shown in the figure, the respiratory bronchioles, sometimes called the terminal bronchioles, include the alveoli and the last several branches of the tracheal bronchial tree. There's George. He didn't answer my call yesterday. Is he? Okay. So deoxygenated blood is carried from the heart to the lungs by the pulmonary arteries and the arterioles. Gas exchange takes place in the capillaries, and oxygenated blood is carried from the lungs to the heart by the pulmonary veins and the venules. Okay, the tracheobronchial tree, there are 16 to 24 tracheobronchial branches. The entire surface of the alveoli and the terminal bronchioles is covered in capillaries and participates in gas exchange. Everybody knows the mediastinum. So the pulmonary blood flows from the heart to the lungs via the pulmonary artery. Pulmonary artery branches into smaller arterioles, and the capillaries. More gas exchange takes place between the lung bases and the circulatory system than between the apices, or the top of the lungs, and the circulatory system. Pulmonary capillaries are narrow, and red blood cells normally pass through a single file. Patients with COPD and a chronic hypoxia often generate more red blood cells, making their blood thick. The effort to push blood through the pulmonary capillaries can strain the right side of the heart. Right-sided heart failure because of COPD is known as cor pulmonale. So there's a fancy $5 word. Did you know that one? I didn't know that one either. I learned just as much with the students going along with what I learned. Do what? Teach? Yeah. Honestly, yeah. All right. We know the mechanisms of respiratory control. Various forms of heart failure can be caused by changes in fluid balance, right-sided heart pumping pressure, and left-sided heart pumping pressure, which is what we talked about earlier with Cash, with his mitral valve and his tricuspid. Everybody knows what the thorax is. Yeah. All right, we know what minute ventilation is. So renal status plays a pivotal role in ventilation. The kidneys play a part in controlling fluid balance, acid-base balance, and blood pressure. These factors affect the pulmonary mechanics and the delivery of oxygen to body tissues. Patients with severe kidney disease often present with respiratory signs and symptoms. Patients with CHF because of renal disease can be difficult to manage because diuresis may be difficult. Acid-base disturbances may cause hyperventilation, because what are we trying to do? Blow it off? That may be mistaken for respiratory disorders. So hypoventilation, we know, is carbon dioxide accumulates in the blood when the lungs fail to work properly, combines with water from bicarbonate ions and hydrogen ions, resulting in acidosis, impaired ventilation caused by a variety of factors. So so respiratory alkalosis causes numbness and tingling in the hand. May complain of respiratory alkalosis will ultimately lead to carpopedal spasm, in which hands and feet are clenched into claw position. The traditional therapy of having the patient rebreathe his or her own carbon dioxide from a paper bag or from a partial rebreathing mask can be dangerous. Patients quickly exhaust the oxygen in the gas they are breathing. Rebreathing carbon dioxide can cause hypoxia. Hyperventilation in a patient with acidosis may be the body's attempt to raise the pH level to normal. Examples are Kussmaul's, sepsis, and shock. Should not be treated by rebreathing carbon dioxide, and it's important to rule out all other causes, so your H's and T's. All right. So of course we want to do a respiratory assessment. We know a range of dangerous situations and toxins are associated with pulmonary complaints: diminished oxygen concentrations in closed or improperly ventilated spaces, carbon monoxide or irritated gases, or highly contagious respiratory illnesses. So respiratory diseases can, of course, impair ventilation, diffusion, perfusion, and a combination of all three. The most common complaint is dyspnea. Most common cause of dyspnea is hypercambria, which is too much carbon dioxide in the blood. This condition can be caused by inadequate ventilation. Some patients may be hypoxic without any associated dyspnea. Always evaluate the patient's oxygen saturation. So is the oxygen saturation actually going to give us a factual readout? No. So what are we going to do? So, good. Rapid onset of dyspnea may be caused by acute bronchospasm, anaphylaxis, PE, and a pneumothorax. So paroxysmal nocturnal dyspnea presents suddenly in the middle of the night and may signal left-sided heart failure. How many times do we see that? Can't breathe in the middle of the night? Pretty frequent. A patient's ability to move air may be hindered by factors that limit the diaphragm movement, restrict chest wall movement, and disrupt the integrity of the thoracic cage.
Most of those don't lay down to sleep. Sit up in them chairs.
All right, so we know in our assessment, we're going to note the O2 sat at rest and while simple exertion, We do that most commonly when we're getting up from wherever we're sitting into the cot, or if we actually have to carry them. Increased work of breathing, anxiety, hypoxia, or fever can trigger tachycardia, diaphoresis, and pallor. The heart rate often decreases in patients as patients respond to treatment. So this is a pretty sickly fellow, isn't he? Is this tripoding? All right. If a patient is willing to lie flat, it may be a sign of a sudden deterioration or in the condition. A patient may be holding his head in the heel-tit chin lift or the sniffing position. Is he in sniffing? To maximize airflow through the upper airway. That sniffing position may indicate an upper airway swelling or the patient trying to maximize airflow. Fatigue patients with severe respiratory disease may present with a head bobbing. That is an ominous sign of decompensation. Yes, thank you. All right. Is this a sick baby?
Yeah.
Why is it sick?
The nose flaring, the chest something,
Okay.
I have pulse pressure changes.
Profound endothoracic pressure changes can cause peripheral pulses to weaken or disappear during inspiration. Pulses are easier to palpate during exhalation, which is pulsus paradoxus. Don't worry about that. We know our primary surveys, so I'm not going to bore you with any of that. We went through abnormal breath sounds on our game. Both of our games. You guys did better on the second one. I'm just proud. I was very proud. What does the death rattle sound like?
Anybody else? I know. It's like when you're breathing and it's just like fluidly filled.
Shayna says raspy, fluidy filled.
When you hear it, you know it.
Yeah. It describes in word form. It says low-pitched gurgling, sometimes heard when patients can no longer clear their own secretions.
Just like that.
The most ominous breath sounds are no sounds at all, which indicates the patient is no longer moving air enough to ventilate the lungs. So we like noisy breathing as opposed to no breathing, right? Shayna said it depends on who it is. So noisy breathing is obstructed breathing. We know this. Snoring is partial obstructing by an upper airway, mostly by the tongue. Gurgling, fluid in the upper airway. Stridor is harsh, high-pitched. A sound during inhalation indicates a narrowing from the swelling of the laryngeal edema. Quiet breathing may suggest hyperventilation, shock, diabetic ketoacidosis, or sepsis. And we learned in our first subtopic that our sepsis, we'll probably need to look at our sepsis protocol. And honestly, I mean, other than counting respirations, I never thought of listening to what the actual respirations sound like. Are they loud or are they soft, or, you know, they're breathing 22 times a minute or 24 times a minute, and, you know, non-labored or labored or whatever. Sputum. Note if the patient is coughing up any discolored sputum. Maybe mixed with blood, pulmonary edema fluid, aspirated food particles, or debris from dead infectious organisms. Yummy. Stop. Determine. Shane is getting sick. She's got her own infectious organisms that she's trying to cough up over here. Determine if the color or amount of sputum has changed from normal. Fever and chills with increased sputum production is a sign of infection. Get Granville back in here to stick his fingers down that guy's throat again.
Stop it.
Blood-tinged sputum is a warning sign that tuberculosis or the airway blood vessels have broken, forcing coughing from forceful coughing. Pink.
I see that a lot. You know, they have pink tinge.
Yeah.
Because they've been coughing for a while.
Yeah.
Been sick for a while.
Mhm.
It's pretty normal.
Well, you get it too. I'm coughing up blood.
Yeah, it's not.
Yeah. Yeah. Pink foam or froth is a sign that air is forced through the pulmonary edema fluid, as in cases of CHF. Note purulent or pus-like mucus color and change of any other characteristic. Poor Shana.
I don't know anybody can be a respiratory therapist.
I don't
That's
know.
the
Um,
grossest thing. I can handle the vomit over that sound in my truck. It just,
I think I can keep respiratory.
oh,
No,
wow.
not me.
Well, me, just to hear it makes me,
Next
What
time
again?
you can, I'm just right there beside him. Come on, buddy.
Mhm.
We're
I
going
don't
through this.
get with them, but yeah, I'm just that, and trachs,
Oh, no.
suctioning out trachs. I'm just like, that is just so gross.
So abnormal breathing patterns. Scroll down here. Where am I at? Most of the brain's respiratory centers are in and around the brainstem. Apneistic breathing caused by damage to the pneumothoracic center in the brain causes a short, brisk inhalation with a long pause before exhalation, indicates severe pressure or direct trauma to the brain. Biot respirations or grossly irregular respiration patterns with lengthy apneic periods. What did we say the other name for biot respirations was? The old name? Do we remember? We need to look it up.
No, that sounds like the reason people put on CPAP.
Yeah. This is seen when there is damage to the center that controls the breathing rhythm. Cheyenne Stoke, ataxia.
Respiration.
Cheyenne-Stoke respiration pattern, breathing deeply, gradually increases and then decreases, followed by a period of apnea. Apnea period usually brief in relatively healthy persons, exaggerated respirations in patients with severe brainstem injury. We know what those are. We're not going to look at that. Everybody has a hard time saying as it is. Is that good or bad?
They just had them. It's a little cyanotic, but if they just had the baby, then they may come out like that and have to be
Good.
warmed up.
Terry said that may be normal, may be cold, may just need to be warmed up. It's just out of the oven.
And when they get out of the oven, they cold because of it.
So various variations include cyanosis. A healthy hemoglobin level in adults are 12 to 14. At about a 5 gram per deciliter desaturation, a person will begin to show blue cyanotic discoloration. Some patients in cardiac arrest have a deep blue skin, although some are pale. Cyanosis may develop earlier in patients with high hemoglobin levels. So why would they have a high hemoglobin level?
If they're sick, there's that one thing we were talking about, is they have a high hemoglobin level. Now, I don't remember what it is right now.
And come back to that. Patients with acute chronic bronchitis may have a chronic peripheral cyanosis, dark brown skin. Everybody knows on African Americans or darker colored individuals that we need to check the mucous membranes. Says they may turn brown from high levels of methamoglobin. How'd you say it?
Methamphetamine.
No,
It's globulin, methylmoglobulin from nitrates, and some toxic exposure more evident in venous blood than the skin and mucous membranes.
yeah, they always say checking them out.
Check for dehydration. dry, cracked lips, furrowed tongue, sunken eyes, which I think is dry, cracked lips. You're going to see that all winter. Respiratory distress, transport to your closest appropriate facility. We know our most common complaints. We know our reasons, know our sample history, secondary assessment. Our neurologic, we're going to check our GCS. An increase of partial pressure of carbon dioxide has sedative effects if the lungs are not functioning correctly. Oxygen may not be delivered to the bloodstream, and carbon dioxide may not be removed from the body. I'm going to check for tracheal deviation. Has anybody seen that? Tracheal deviation? Consider palpating the trachea at the suprasternal notch.
But I don't think it was due to respiratory, it was due to trauma.
Like a hemo or a.
That would be fun to
Mm. Mike said his was due to being punched in the throat.
You did it yourself?
I punched you in the throat. We went, oh shit.
Do the other side. Put it back. Put it back.
So on your chest and abdominal exam, especially in your trauma patients, a combination of JVD and hepatomegaly may present in right-sided heart failure. Pressing gently on the liver when a patient is in respiratory distress is sitting in a semi-Fowler's position will cause the jugular veins to bulge even more. So that is called the hepatojugular reflex. So where would we press? If we're pressing for the liver. Shabam?
But why would you want to see it pop more? I mean, why would you want to see that? Why would you want to do it? What's the purpose? Is it just saying, oh, you might see it because you did this, not to be worried, or what's the comment mean?
I think it's just more of your examination findings. Says feel for vibrations in the chest as the patient breathes. Chest or abnormal trauma can cause respiratory distress. So it's basically, I would say, if you're looking for a liver injury, if you're pressing on the liver and it's,
And it pops, that's a good sign.
Like a lot.
I think it'd be a bad sign.
But I mean, it's
Yeah.
it's a sign.
Yeah.
for that.
Yes.
And that's what I'm saying. Why would we want to press on the liver is what I'm trying to get.
Yeah.
at.
To see if there's injury to it.
Appendix on your right, spleen, rear left, and stomach area.
GL blank.
You have got no. You have a gallbladder?
Yep.
I was like, you may just be asked.
Tasia,
Yeah.
I gotta go take this White River.
Okay. Okay.
Bring this White River.
Alrighty, we got you down.
Yeah.
All right, so we know our vital signs and our monitoring devices. We know how to reassess.
You can take it all. Bye. Bye.
This says oxygen saturation. We keep going down. We're at 94% on our normal patients. We know our COPDers and our CHF is going to be different. Psychological support, I think that has really been emphasized. This
And they say
research.
now, and Ron say now that they can get all the way down to 89. and it's still
89.
not a problem.
Mhm.
Before, it
As
was
long as they're
always,
perfusing.
you went to
Mhm.
94, not so much anymore.
Yeah, that permissive, I think it's blood pressure, but I think it's permissive anything anymore. As long as they're perfusing and they're functioning, you treat less, which it sounds like if they're under Baxter protocol, sepsis, they're wanting you, that's the most aggressive thing I think we're treating is sepsis, but I guess basically because it's so deadly. But you know, that old school, it's hard to, if it's 95 or less, it's hard not to
Want to put
treat
more.
that. Yeah. Yeah.
Panel's not breathing, that's why we're.
Mm-hmm. So what I said a while ago was that a lot of, and not just with me, but it was in the first time that I heard it, and I guess that's the reason why that it stuck with me is because I had seen it in a couple of my presentations, is the psychological support. It's a lot of what we're doing is psychological support. Breathe with your patient, talk with your patient type thing. So
A lot of times it'll raise it on its own without you raising it.
Yeah.
I've done that, but it doesn't stay because they're going with us because they've got the anxiety anyway.
mhm,
You can't keep them in that mode that long.
yeah,
You know, I'll be doing it, it'll be great, I'll look around, do something else, and then I have to go back and start all over again until I can breathe. So you're breathing down,
Yeah.
get it back out. We
Yeah.
just can't do it, we can't make a difference in the long term
yeah,
whatsoever because they'll go right back as soon as you start doing something else. When they quit focusing, they go back to it. So is this current? They still want us to put them on it if it's under 94.
this is what they're teaching in school right now. It's 94. I mean, you're gonna have, just as well as I do. You go to right, and if you go,
they call us for shortness of breath, and they're 94. I'm gonna give it to them anyway because they're complaining.
Yeah.
Shortness of breath.
Yeah.
I'm not gonna say no. You can't have it. You're not.
Yeah.
You can also just put them on.
Oh,
You can just put them on one later, make it feel better, or you have.
yeah,
What I'm saying is that's their complaint. I'm gonna treat it, not treat it because the machine says it's a high enough number.
I couldn't tell you how many times I took a patient to the ER that it was respiratory, and you have them on a nasal cannula, a couple of liters. What was their O2 side initially? 92. They turn it off.
They turn off. They turn
Yeah.
off immediately. If you
Yeah.
don't- But that's okay because we're doing what we can in the short
Mhm.
term. If they want to change up,
Mm-hmm.
that's up to them. A lot of times we'll hook it back up and then they'll come back and ask, what was it? Room air. Well, it doesn't really matter because they needed it.
Yeah. Yep. All right. Varying benefits of administering a bronchial dilator. Those without bronchial spasms will benefit only slightly, and oxygen concentration may need to be reduced while treating with aerosol sprays. Bronchial dilators are ineffective in cases of pneumonia, pulmonary edema, and heart disease because, of course, we're not treating the core of the issue, we're just treating a sign.
Mm-hmm.
So fast-acting bronchial dilators, most common types used by working the beta-2 receptors in the lung, produce almost instant relief and are often misused. How did we say that word earlier? Ipotropium?
Yeah.
Ipotropium, whoa, is now available as an aerosol inhaler, a combination of albuterol, a beta-2 antagonist, and ipotropium is an anticholinergic, is available in an aerosol or in a meter-dosed inhaler. It dramatically improves the quality of life for patients. We know what this is.
So are we going to be, does Baxter carry down those?
I believe so.
Yes.
So we will be able to carry those.
Well, you had protocol. Did we not go over it?
Nope.
I don't remember seeing the dual notes on there. That's why I asked. Albuterol was on there, but I didn't remember seeing the dual notes. But
So patients that treat at home, most aerosol treatments run with a small air compressor. The patient may only be receiving 30 to 40% of oxygen via treatment. Aerosol may be contraindicated if removing a patient's non-rebreathing mask causes further hypoxia, which we have on most of ours, like our CPAP, we have where we can attach it to it, so we don't have to worry about that. We know how to administer a bronchial dilator.
oh, I need to bring that up. Our masks we use for the albuterol mask, they don't have the thing to hold them on their nose anymore. So what I'm finding is a lot of times I have to hold their mask on while they're doing their breathing treatments.
So Terry's stating that on our nebulizer masks, that the little metal piece is no longer at the top, so she has to hold the bridge of the nose to make sure that the medicine is
Hold the
not.
mask,
holding the mask, yeah, to make, yeah, and tape it, yeah.
But I mean, that is something that's different. I don't know why we don't have those anymore where we can just,
Cost effectiveness, I'm sure.
That little strip of aluminum was probably, 50 cents.
well, back to, I don't know what Baxter carries. That's what we'll be carrying, so maybe it'll have it. I don't know. So I guess I brought it for no reason, but whatever.
Somebody knocking?
Maybe come in.
Oh, okay. So tips for your patients to avoid common errors include the patient should inhale deeply as the inhaler is discharged. The medicine must enter the lungs to be effective. Placing the inhaler directly in the mouth often causes the medication to land on the pharynx instead of being breathed into the lungs. Patients should not blow into the spacer. They should suck the medication out of the bottle. The best particle disposition comes from the laminar, Laminar flow, laminar, that is smooth and low pressure. Sucking too hard causes turbulent flow and many particles stick to the trachea and the large bronchi. Many spacers make a harmonica-like sound if the patient sucks too hard. The patient should inhale the medication deeply and then hold their breath for a few seconds. It's not always possible with a patient with dyspnea. Many may cough immediately after inhaling, which I think they should. You should encourage that especially. Make sure the inhaler contains the medication, of course. Patients should keep track of how many puffs they have taken and discard their inhaler after the recommended number of uses. Keep the spacer and canister holder clean to avoid inhaling dust and particles. Dry after cleaning to avoid the growth of microorganisms. After using a corticosteroid inhaler, rinse the mouth with water or mouthwash. Residual corticosteroids may lead to thrush. Did you guys know that? I didn't know that. We pretty much just talked about the failure.
Adults end up with thrush just because they've been on a steroid.
All right, so corticosteroids reduce bronchial swelling or edema, a variety of adverse reactions, affects Cushing syndrome, classic moon phase, and generalized edema, rapidly change in blood glucose levels. Did you guys know that? Blunt the immune system, require slow discontinuation, prescribe 1 to 2 weeks therapy to avoid long-term use. Inhaled corticosteroids do not seem to have the same adverse effects as oral ones, becoming the standard in asthma and COPD treatment. Intravenous corticosteroids are common in medical emergency. A single bolus IV of corticosteroids does not seem to cause negative long-term effects. What do we have a corticosteroid in the truck? What's DEC?
Yeah. Dexamethasone.
Dexamethasone. Yeah, DEC. Is it a cortico? Okay. Methylprednisone and hydrocortisone IV boluses are used for acute asthma attacks or acute COPD exacerbations. Onset of drug action takes hours, and consult your local protocols and medical control. Why would we want a vasodilator? Is it going to help in the bronchial tree? Why is that? So, okay. So Shayna said it dilates everything. So treatment for pulmonary edema, decreasing preload. Nitrates can be used if the patient has adequate blood pressure and does not take a I would say that's Viagra.
Yeah.
Or Cialis. Morphine sulfate is not likely to increase venous capacity, but does decrease anxiety. I'm not going to give morphine. I'm sorry. I'm not going to give morphine to a. It seems kind of crazy to me, but. All right. So restore fluid balance. You give this to younger patients. Too much fluid in elderly patients or patients with cardiac dysfunction could result in pulmonary edema. Assess both breath sounds before and after giving fluids to make sure the patient is not overly hydrated. Hydrating patients with pneumonia may cause pneumonia to blossom or expand. So let the staff at the medical facility rehydrate the patient. Diuretics. Giving diuretics to patients with pneumonia or asthma may dehydrate, opposite effect, and cause secretions to plug in smaller airways. Diuretics are used to help reduce blood pressure and maintain fluid balance in patients' heart failure. Diuretics help remove excess fluid from circulation, keeping it out of the lungs of patients with pulmonary edema. Loop diuretics are commonly used in emergency situations. Thiazide diuretics are often used to treat high blood pressure and heart failure. So diuretics can cause potassium loss. This can cause dysarrhythmias and severe muscle cramping. Patients with renal failure may require large diuretic doses who have, or they may have no response. Here's our CPAP and our BiPAP. May include intubation. We know what CPAP and BiPAP does. We went over our events already. We know how to intubate. How much time we have? All right. It is 2:56. We're just going to call that good. If everybody else is good with that. All right. Maybe you learned a little bit of something. If anybody's interested in that slideshow, I can make it available to you. If not, we just wasted an hour for good measure. And everybody's good with that? Okay. We'll see you in 10.